gentlemen, we have a distinguished professor with us today, along from USC, Gary Kreps. Started off with very humble beginnings, teaching at Chapman University.
Oh, I thought
back in the days. And he got his Ph.D. with our program here. It was called Unit Communication, the White Model of Organizing, Field Experimental Test and Reevaluation. A model he's still using today, right? White's model. He left USC, went to Purdue, Rutgers, then he became a senior research fellow at NCI. He's an expert in cancer risk, aging. He gives some talks about how communication and research on aging populations that I attended in Washington. Gender, servicing the needs of diverse communities. He then became dean and founding head at UNLV and Hofstra communication programs. He then became founding chief health communication and informatics research branch at NCI in 1994 to 2004, really putting communication research on the main fray there at the Washington government. In 2004 and today, he is a University Distinguished Professor at George Mason University, Chair of the Communication Program, and founding Director of the Center for Health and Research Risk Communication, among other things. I'm summarizing 100-page CV. Today, he is going to talk to us about examining the health information seeking behavior of Korean American immigrants, implications for communication interventions, and cancer control. Ladies and gentlemen, Professor Gary Kreps.
Well, thank you very much for having me, and welcome back to campus. I realize this is the very first day of the new semester. You all are probably trying to figure out where you're supposed to be going, what you're supposed to be doing, what classes you're taking, figure out what's up and what's down. So I appreciate you coming here to speak with me today. I'm really pleased to be back at USC. I spent 3 wonderful years here, learned a lot, and enjoyed it immensely. So it's been really nice to come back and see how the campus has grown and the program has flourished. And I'm really impressed with your outstanding faculty and accomplished students and amazing facilities. I was telling Michael I'm so jealous of the amazing infrastructure you have here, and what a great opportunity you have to study communication and to make a difference in society. The work I do examines the role of communication in healthcare, health promotion, disease prevention. For many years I've been focusing primarily on what I call vulnerable or at-risk populations. And there are a lot of different groups who are vulnerable for different problems. One of the groups that I do a lot of work with are immigrant populations. And that's particularly appropriate here in LA because this is such a melting pot of different groups of people coming from different parts of the world, speaking different languages. And it seems to me that immigrants have particularly difficult times getting access to relevant health information, getting access to the best care, and they have tremendously poor outcomes from many different health problems, but particularly for cancer. And the cancer is one of the domains that I do a lot of work with. It's one of those issues that is basically connected to all of our lives. I mean, every one of us either has dealt with cancer issues ourselves or have friends or family members who are dealing with cancer or have dealt with cancer. It's a pervasive problem. And I've learned that cancer is one of those diseases that is particularly related to access to information, that the people who have the best information have the best opportunities to survive with cancer and to confront cancer successfully, both in terms of prevention, early detection, treatment, and increasingly survivorship. We've made some really major changes in cancer over the last 20 years, and one of the big ones is that for most people, cancer is no longer a killing disease. It's a disease that people live with, a chronic disease. And we need to help people live with cancer more effectively. However, if you don't detect cancer early, your chances for survival are much worse than if you detect it early. And detection is a big problem, and that's one of the things I focus on. So let me talk a little bit about what's going on here. A basis for a lot of my research is that health communication research can help reduce health risks, disease incidence, morbidity and mortality, improve quality of life. I say it like it's a statement because I really want to believe it, but it's really on hypothesis. This is a testable hypothesis, and almost all the work I do tests that hypothesis, and I'm glad to say that a lot of the work I've done actually supports that contention, that we can make major advances. And I think it's one of the exciting things about studying communication is that you really have an opportunity to make a difference in the world, to help people and to reduce threats. Communication cuts across the entire continuum of cancer care. It's not just a treatment issue. We often think of health communication in terms of treatment, communicating with your doctor and making health decisions, but it's an important, critical part of everything we do, from prevention, knowing what is the risks, what you can do to prevent those risks, early detection, diagnosis, treatment, survivorship, and even an end of life. So the work that I do cuts across all of those domains. And there are opportunities for you to make a difference at each of those stages across the continuum. So if you're thinking about applying your work to the health domain, you can do it a variety of different ways. In this study, this has been a long-term project. I've been working on this for about 3 years now, and I probably have another 3 years into it. Most of my research is very long-term because I deal with big, intractable issues. Most of my work is field-based. I'm an interventionist. I develop evidence-based interventions to try and change the status quo, to improve things. But there are a lot of social policy implications for my work, so it's not quick. So typically what I do is I break it down into different segments, multiple phases, and I kind of report my work as I'm going along. This is kind of a mid-phase part of this research program, although I'll just explain the entire trajectory to you. In this case, I've been working with a variety of different immigrant groups. So one of the groups that is very prevalent in the Washington, D.C. metropolitan area where I live are Korean Americans. There's a very large Korean American population. Are there any Korean Americans or Koreans in this group? Oh, good. So you can verify that what I'm saying is true. I've learned to depend very much on my Korean colleagues. It's very weird for somebody who's not from a immigrant group to study that group, and it's really dangerous. There's a tremendous hubris here for me to think that I would understand this community. And so I've learned very easily, usually through the School of Hard Knocks, that I'm usually the dumbest one in the entire research project because I don't understand the culture tremendously. So I work very closely with a number of colleagues who are ambassadors who interact with the community. And I typically provide kind of the research framework, help develop instruments, help analyze data, but I don't typically collect the data or interact directly with the community because I'm not particularly well trusted. I don't speak the language. I'm not connected very well. So I want to let you know that right away, that I'm not assuming to know everything there is about Korean Americans. But Korean Americans typically experience serious disparities in cancer outcomes. Much higher morbidity and mortality. Even though they don't have higher incidence rates, the outcomes from cancer are much worse. More Korean Americans die from cancer, and we want to know why that is. One of the things that we've learned is that there are very low cancer screening rates for Korean Americans. Screening is what people do to detect cancer, hopefully at an early stage. And the earlier the stage of detection, the more treatable cancers are. If you can detect most cancers early, survival rates are very high. But if you detect it late, particularly after it's metastasized to other sites in the body, it's much more difficult to treat. And mortality and morbidity is much higher. Late-stage diagnosis is very common for Korean Americans, stage 3 and stage 4. It only goes to stage 4. So when you're getting a stage 3, stage 4 diagnosis, it's very serious, very dangerous. Treatments are much more intensive. Success of outcomes are much less likely. There's big problems, so we want to encourage more stage 1 and stage 2 diagnoses. We found that a lot of Korean Americans, even when they're diagnosed, don't get the best care, don't have access to the best treatments. So it's not just a prevention or a detection issue, but it's also a treatment issue. We've also found that many Korean Americans don't have great access to cancer information, and that's a problem. And there are very limited community data about Korean Americans as a group, as there are about many different immigrant groups. One of the things that I've done over the years is to develop surveillance tools for trying to identify where the public gets access to health information. When I was at the National Cancer Institute, I helped to start the Health Information National Trend Survey, which has been around for about 10 years now. How many of you are familiar with HINTS? Do you know what HINTS is? If you don't know, you should find out. If you get a chance, go to Google and type in HINTS, H-I-N-T-S, and NCI, and you'll come to a web page that will tell you all about the HINTS data set. It's a biennial survey every other year that we've conducted with a nationally representative sample of Americans with over-representation of different minority groups. We do it in both English and Spanish. We typically have about 7,000 or more in our people in our population. The data are very revealing. They tell us where people get access to health information, what they know, even more important, what they don't know, or what they think they know that's not true, which often is a really big problem, where they prefer to get health information, who they trust, who they think are credible, who they get information for, what different media they use, and then we track that over time, and we're able, that's why it's a trend survey. We look and see what the trends are and how things are changing, especially as the media environment is changing. We want to see whether things are happening, and we also find out what people know, particularly related to different health campaigns that have been conducted, to see whether or not they understand information, if they recognize information. And a lot of times that information is very revealing. We're hoping that we can use that information as an evidence base for developing interventions. Most health promotion interventions are based on good intention, but very limited data. And that's a problem, because it's like shooting in the dark. You don't really know where you're going and what you're doing, and the chances of success are very low. So we want to kind of shine light on what the information environment is and what the communication demands are, so that people can do a good job of developing campaigns that are evidence-based and targeted. People need timely and accurate health information. It's probably the most important resource you have when you're confronting health issues. This is not only important for you as somebody dealing with your own personal health, but also really important for you as an advocate for your friends and loved ones. I really believe strongly, and I push my students and colleagues to be active advocates for their friends and family members and colleagues, so that they can help them get access to information. When you don't have relevant information, you have limited options. You don't have the evidence for making good decisions. It's hard for you to kind of build the collaborations that you need to get things done. It's hard for you to interact with your healthcare providers. It's hard for you to intercede within a very complicated and often not very friendly healthcare system. So information is critical. Providers and consumers both need relevant health information. Salient and motivating cancer information, which goes beyond just getting information, means providing information in ways that is relevant, involving, and persuasive, is critically important for influencing health behaviors and improving outcomes. And let me say up front that influencing health behaviors is very difficult to do. Most of those health behaviors don't happen by accident. They are based on a long history of cultural upbringing and expectations and social norms. Changing those behaviors is not easy. Otherwise, nobody would smoke, and everybody would eat healthy diets, and everybody would exercise regularly, because we all know that those are good things to do. But our behaviors are not always tied to our logic. They're tied to our cultural upbringing and our psychologic about how we think about the world. Relevant health information can reduce uncertainty and enhance quality of life. And Michael mentioned that I've done work with Weich's model of organizing. It's a model that I use in a lot of my work that's based in part on uncertainty reduction theory, that uncertainty and confusion and complexity and equivocality are really big issues in helping, in preventing us from making good decisions and engaging in good behaviors. And one of the areas that is most complicated and confusing for people is dealing with health issues, because we don't always have good information. We're not sure what's going on. We're not sure what to do. And so one of the things that I try to do is to build communication interventions that reduce uncertainty, that improve predictability, that help people make good decisions. Cancer in particular is a very complicated issue. There's not one cancer. There are thousands of cancers. We teach, think about it as kind of an amorphous thing. And people don't like to talk about cancer. They don't want to think about it. We think that if we talk about cancer, we may be more likely to get it. It's not a happy thing. There's a lot of myths about cancer, yet it's very common. And so we need to kind of deal with that complexity. The cancer environment is constantly changing. There are many new advances, there are new treatments, there are new technologies, and there are significant barriers, particularly stigma, to disseminating cancer information that make it very challenging. So it's not an easy communication area. In much of my research, I found that people who are confronting cancer directly are much more amenable to communicating about cancer, and they're interested in seeking information. But if you don't have a cancer threat, or somebody you care about doesn't have a direct threat, it's the last thing in the world that you want to talk about. So it's very difficult to sell screening and prevention, particularly about difficult types of prevention and screening, like colorectal cancer. It's not a happy topic. People don't want to talk about it. They don't want to think about it. It sounds painful. Don't go there. Leave me alone. It's a difficult area. Yet it's one of those areas that we really need to talk about. The hint survey is become a tool that I've used. One of the things that I wanted to do with hints when I first developed it was to not just have this national survey, but to have this survey serve as kind of a foundation for a much larger, robust international research program. And to help with that, we made everything that we do with hints, my colleagues at NCI and I, open source. It's easily available. You can get all the hints data just by going to the website. You can analyze 4 or 5 applications of hints data. You have all kinds of tools to help you do that research. The problem is that we made the hints data set so easily available that there's been a huge cottage industry of secondary analysis of hints data that have gone on, and people haven't done the additional hints research that I hope they would do, which is to use hints research instruments with different populations. So instead, the same general population has been studied more and more, and that's been a problem because there are weaknesses with that national data. This is what the hints tells us. I've already told you this. There are several major limitations. First of all, it's a national data set, which is very difficult to translate into local problems. Most cancer problems that you want to deal with are at a local level. It's in your community, in your family, and the hints data set tells you about large trends. There's undersampling of vulnerable populations, even though we do it in English and in Spanish. There are a lot of people who don't speak either of those languages very well. We tend to aggregate data about immigrant populations. For example, all Latinos are put into one group, and all Asian Americans are put into one group, which is insane, because there are tremendous variability among those groups. But we didn't really have enough of any one group to really make those kinds of individual comparisons. So my hope was that we would build on that and flesh out those limitations by doing more local special population studies of it to increase the limited depth of information, and also to find out why people are having the problems they're doing and how they need to get information and what can you do next. Survey research is a really great tool. It gives you great information, but there's not a lot of depth. Gives you general trends, so you need to kind of supplement that with additional research, and that's one of the things that we're doing with this research program. So in this program, what we're trying to do is to assess how members of the Korean American community, KAs are Korean Americans, what their health information needs are. We want to find out what kind of information gaps, and there's a large literature on information gaps that you should be aware of that's very interesting, that talks about what people know and what they don't know. We want to find out what people's communication preferences are. We want to develop culturally sensitive evidence-based interventions so that the communication reflects their needs, their expectations, and their reality. Then we want to implement and assess the intervention program and institutionalize and sustain the best practices. Hopefully this leads us to developing a new model for reducing health disparities. That's the really big goal. Korean Americans are only one of many different groups that have problems, and what we're trying to do is come up with a model or a strategy that we can use to help people who are having a difficult time getting information and because of that have bad outcomes. So in this study, there's kind of a unique design. It's complicated. We're building upon an existing research program. We're using the HINTS instrument, translated into Korean. It's a multi-phase evolutionary research design, which means that as we complete one phase, data that we've gathered influences what we do in our next phase. So it's not, you don't have it all figured out ahead of time. We're learning as we're going. So it's a kind of a learning system. We're using a community-based participative approach, which I've learned, particularly in health promotion, is the best way of getting people to accept what you're doing and to make changes. We're using a multi-methodological data collection strategy that uses both quantitative and qualitative methods. And hopefully we're developing evidence-based, culturally sensitive interventions that we're going to test. We use both formative and summative evaluation to assess them. And the focus of the whole research program is not just to advance knowledge, which is a wonderful thing, but also to translate these data into programs, practices, and policies that will make a difference in society and will be sustained over time. Which more and more I see as kind of my mission for my work. I really want to advance knowledge and test theory, but I really want to make a difference. And I think as communication scholars, we have a really unique opportunity to use our work to improve quality of life and actually save lives for many people, which is really heady stuff. I think it's pretty amazing. Now, I have a broad theoretical foundation. I've already mentioned Weick's model of organizing. The whole research program is based on this notion of equivocality. Health information reduces equivocality, reduces uncertainty, helps us make decisions. But to reduce equivocality, we need to come up with strategies, appropriate cycles, communication cycles, to help people work through problems. And so that's this goal here, is to try to figure out what are the appropriate strategies for communication to reduce uncertainty. It's based on the knowledge gap theory and about knowledge gaps and health disparities. That when people don't have adequate information, they're less likely to access the best care and they have worse outcomes. It's based on cultural competency theory that says that the best interventions are culturally appropriate for different audiences. And I don't know if you know much about health promotion, but most health promotion is kind of like a one-size-fits-all strategy. Everybody likes to do these national campaigns that really don't make sense for most people. It's a real problem, and they're not culturally competent. And while there's a lot of health information, cancer information in particular out there, most of it is totally inappropriate for Korean Americans or many other different groups. We're using a diffusion of innovations model where we're trying to work within the community through social networks to make changes over time. So we're getting to the intervention phase. We're also using ecological models of health promotion where we understand that most health behaviors are rooted within the social system. And so it's not just an individual issue, we're trying to deal with the Korean American community. And we're using the community as the basis, kind of one of our levels of analysis, not just the individual. We're also basing a lot of this research on models of immigrant and refugee health models that talk about how different groups get access to information and make changes. In many ways, this is similar to the metamorphosis research that Sandra Ball-Rokic and her group have been doing that also takes kind of an ecological and immigrant and refugee health model. I find it to be a very rich approach. The problem is that it takes a lot of care and feeding. You know, it's not easy to work with a group. And it's not easy to get a group to trust you and to get people to work with you. So you've got to have a lot of investment. You've got to have a lot of meetings. You've got to, get people involved. You've got to get people to carry the torch for you, which is part of what I do. Is I try to get people involved. We're using a multi-methodological approach. Basically, we're using a quasi-experimental design for the evaluation, where we're going to be doing pre and post analysis. We don't have control groups, obviously, because it's a field study, so it's a quasi-experiment. We really don't have control groups either, so it's kind of a limited experiment, but we still have some good pre and post data that we can use to let us know what's going on. We're using survey research with the Korean American version of the HINTS survey. We're doing ethnographic research with in-depth interviews, observation, and focus groups, and we're actually collecting a lot of those focus group data right now. We're doing textual analysis and obtrusive measures where we're looking at existing records. I find that there's tremendous latent data available about health issues that we can use to observe what's going on. Most evaluation research is based on interview-based self-report data where you say, did you like it? Did you do it? And there's a lot of demand effect, and you never know whether people are telling you the truth or not. So I love getting unobtrusive measures using archival data to see what actually has been done. We have access to all kinds of health records that tell us a lot that we're using. And then we're using both formative and summative evaluation to kind of figure out how we can improve, and then what's worked, what's not, and how is it cost effective. In terms of the qualitative research tools, cumulative quantitative, the survey, the HINTS survey translated into Korean, we administered to a large sample of Korean Americans in the DC metropolitan area. We did quantitative content analysis of Korean media to see what kind of coverage there already was within the media about cancer issues. We did archival analysis of community health records and health promotion documents, and eventually we're going to be doing a field experimental test of the interventions, which we haven't done yet. We're gathering some of those pre-data right now. We haven't gathered the post-data. In terms of the qualitative tools, we did in-depth personal interviews with community leaders, both in Korean and English, mostly in Korean, based on what people's preferences were, to assess health information needs, gain access to respondents, and through that interview process, we recruited people in the community to work with us. The interviews are not just a good source of data, but it's a way of kind of making friends and colleagues within the community to get them to work with us, because we want these folks to carry the water for our interventions. They're the ones that are most influential within that community. We're also doing focus group discussions with community members, both in Korean and English, based on people's preference, to gather audience analysis data about awareness and attitudes. And we're also doing participant observations. Several members of our research team are active members within the DC area, Korean American community, and are actively involved in a lot of the programs that are going on. So here's phase one. We've already done this work. Some of it's still going on. We started off with in-depth personal interviews with community leaders to find out what the nature of awareness of the problem, what was the lay of the land, who are the different influential organizations, where do we get access to people, who are the key leaders. We're getting a lot of background information that will guide our research. And I think that this is really a critical part in almost all field research, is to kind of get a sense of what's out there so you can map out what you're doing. We did focus group interviews with community leaders and other members, and we're continuing to do that now. We started analyzing community documents to find out what information was out there, and we did participant observations. Phase two we've already conducted. We did the HINTS survey in Korean. We administered to 421 DC area residents. We had more than a 60% response rate, which is really great nowadays, because most of the surveys are getting 20 or 30% if they're good. We had a kind of a skewed population. We had mostly female, mostly older, and mostly married. I'm not sure exactly why that happened, but it was something that we detected. One of the things that's really interesting is that the Korean women tend to be very powerful in terms of guiding health behavior within that community, and it's probably true for most areas. So it was actually good to get access, because the Korean women often were getting information for family members. And since cancer is a disease of aging, that the older you are, the more likely you are to get cancer. The older population was particularly appropriate too. I'm not sure what the married part of it did, but we know that we're going to connect to the family, and we see the family as a central intervention site for making differences. Interestingly, we found that even though many people had lived here for many years, most of these Korean Americans did not speak or read English well. We found that it was a very insular community where people did not need to use English, that they could do very well with Korean, which was a real problem because we found out that almost all the cancer information was in English. And so these people were basically not had access to any of that information. We found out that there were low levels of cancer information seeking. People felt that they didn't have access to information, primarily because they didn't speak the language. People who had sought information had a lot of negative experiences. They didn't feel confident. There was very low awareness of cancer information sources. There was a very heavy use of Korean ethnic media and internet, although we found out that those media did not carry much information. There's limited cancer information provided by Korean media, either radio, television, magazines, internet. We found that healthcare providers are trusted but are underutilized, which is interesting. We'll talk about that in a minute. And then we found out that most of the people preferred to get information in Korean. Now, the healthcare providers is a really interesting one because many of the Korean people we interviewed did not have health insurance. And it's not because they were indigent. Most of them actually had small businesses. It's a community that there's a lot of shops and barber shops and restaurants and laundries and nail shops, all kinds of different businesses. But because they're small businesses, health insurance is very expensive for them. And so a lot of these people did not get health insurance and instead preferred to go back to their homeland, to South Korea, to get care, even though that was only once every 2, 3, 4 years. So that you're waiting a long time. Talking about early detection, you can't really wait 3 or 4 years to find out or to get quick treatment. We already have done some of this work. We've content analyzed cancer coverage in Korean media. We've analyzed cancer screening test records from our local. We've worked with the Innova healthcare system, which is a very large healthcare. They have a monopoly on most of the hospitals in the area, so we've got access to records where we stripped names, but we were able to identify people by ethnicity to find out how much cancer screening was going on for Korean Americans, and found out it was extremely low. We analyzed tobacco counseling and referral records. Once again, very low participation by Korean Americans, even though there's very high levels of tobacco use, particularly by Korean men. We analyzed cancer treatment records by site and stage, and we found out that there are several really bad cancers, and most of them were very late stage. So this is verifying a lot of the information we came in with, but it also is telling us that there's a real big problem that needs to change. So we need to kind of change a lot of these issues. We need to increase cancer screening. We need to increase tobacco counseling referral, and we need to get people treated at an early stage. Stage 4, we are at the stage now. In fact, we are seeking funding through NIH to do our intervention research. We've published a lot of the first wave data about the survey results and focus group results, but we want to develop and implement interventions. And so we're planning to do focus groups to follow up on what we've already found, to find out why people are doing what they're doing, and what they would suggest for interventions. We found out that people who are members of community have the best information about how to make changes within the community. They know how the community works, they know what will work, what doesn't work, they know what resources are available, they know what people would do, wouldn't do, what will be acceptable, not acceptable. So we want to be guided in our intervention, not to kind of think that we know what's best for that community. Based on those data, we're going to create multi-channel, culturally sensitive Korean cancer information programs. We're going to implement and refine information based on community feedback, which is formative evaluation, and then we'll continue that for a while to see how that goes. Follow-up, we're going to re-administer. This is the post data. We haven't done this yet because we haven't developed the interventions yet. We're going to re-administer a survey to a large sample of community members. after we've done the intervention for at least 6 months to see what kind of results we have compared to the first and second administrations. We're going to do a follow-up in-depth community analysis. This is also post-data. Personal interviews to see if there are detected changes, changes in attitude, changes in information. We're doing focus group interviews to see whether people recognize that they're more access to information, people feel less fatalistic about getting information. We're going to analyze community documents to see whether there's more coverage, whether our interventions have made a difference with the media, and we'll be working directly with the media. We're trying to do this all without having to pay for media spots by using kind of a media advocacy approach where we encourage cooperation, and that means working with the local media. We'll be doing participant observation within the community, and then we'll be comparing pre- and post-intervention data. This is a follow-up. We're going to be content analyzing cancer coverage. We're going to be analyzing cancer screening test results to see whether there are differences in terms of number of tests done, early detection, better treatment, better outcomes. We'll be looking at the tobacco counseling information. We'll be looking at the treatment records by site and stage and comparing pre- and post-intervention data. Based on what we find, we want to try and figure out what works with this community and what doesn't and why. We want to prepare reports and presentations to disseminate broadly, both within the scientific community and the local community. We want to recommend new policies and practices for the local healthcare system, the public health system, and the Korean American community. And then we're going to try and institutionalize and sustain best practices over time, so that this is not just a one-shot, we're not just gathering information, but we're changing the social system. Here are some of the reports that we've already published. There's a number of studies about some of the early data, and a lot of the information is pretty strong. Sorry about this. One of my colleagues is calling me. This problem when you're a university administrator, you're never alone. There's always fires. Larry knows this story. But here's some of the literature. If you are interested, I can send you reprints of any of these studies. And what I'd like to do is kind of close it down and then open it up for questions and comments and recommendations for you. I'm very eager to get your suggestions as we are refining our research program. This is a really kind of a harbinger of a much larger set of projects. I was telling Michael that we recently agreed with the Chinese Ministry of Health to conduct hints in Chinese for all of mainland China. And we'll be doing that in the next few years. We're just translating the instrument into Chinese, and we're hoping to make some comparisons between Chinese nationals and Chinese Americans. I'm in discussions with folks in Japan and also in Korea to do hints in those countries as well. And we're hoping to make this kind of a global instrument for letting us know where people have access to health information so we can develop targeted interventions. Thank you.
Questions? Any questions at all? Yes.
Gary, given one of what your experiences have been, because this would be very helpful for us, given this medical disconnect, they don't have insurance, and many are going back to Korea for health care. As you go to Korean America, you mentioned your research is very participative in its orientation. What are the challenges that you experience in persuading Korean American community groups in the DC area to get involved with you in your research program? Because surely they're aware of this medical disconnect as well.
We've actually had very, very good success. We've been really embraced. We actually collected our data through many of the Korean churches. One of the influential groups that we learned were the ministers of these Korean churches. And so we worked with them. The reason we got such a high response rate is because the ministers basically told their followers, congregants, to fill out our survey. One of the things that we've been doing is, one of the interventions that we're developing is to help the members of the Korean American community, and there's a strong organization to combine to get access to group health insurance rates, which they've never done before. Everybody's been on their own. They haven't seen it as kind of a community activity. And there's a lot of excitement and interest in doing that so they can get lower rates for everybody.
Now, you mentioned churches. Is that because they already had a health ministry, like parish nurses and that kind of thing, or is your contact actually inducing them to form health ministries along with their spiritual ministry?
There was not much in the area of health ministry. There was interest, and there was a lot of counseling going on. Since there was high morbidity and mortality, the ministers knew that there was a big problem with cancer. They kept seeing people, being diagnosed late stage and dying, and disruption to the community, and so they really wanted to intercede. They hadn't been doing much with it in the past. So there was high sensitivity, but low activation in the past.
Yeah, I was wondering if or how you would distinguish in thinking about strategies of information between health and medicine. Because I could see medicine, I see medicine myself as kind of a universalizing, rational, scientific discourse, whereas health is much more extensive, culturally variable, and reinvented depending on the spaces you're in, the communities you work with. And so how do you, when you're thinking about information, do you distinguish between health and medicine? Do you blend them?
Well, I hadn't really thought about that before, but I guess we've been focusing more on health than we have on medicine. We've been focusing more on people's interpretations about health issues and strategies. There's very little good information about medical science within this community. People trust the doctors, but they don't utilize them very much. Most Korean Americans want to see Korean doctors, and there are not a lot of them. And many of the Korean doctors are not really very focused on prevention and early detection, perhaps because there's such a big treatment issue going on. So they're kind of like running after the problem and not really trying to prevent it. And so part of the issue is that we're not only going to be working with members of the Korean American community, but also working with the Korean American doctors to get them to be more focused on early detection and prevention, and to help them reach out more effectively to that community. We're also going to be working with area physicians to help them learn how to communicate. People who are not Koreans, to learn how to communicate. We're working with the Innova hospital physicians to learn what some of the cultural issues are in communicating effectively with members of the Korean community. We're also working with extended family. And we found that there's a really big difference between the Korean youth, the second and third generation, and the parents and grandparents. And the second and third generation are much more savvy, much more acculturated, and we're trying to get them to serve as better advocates for their parents and to intercede with them within the healthcare system, since they're much more facile with language and culture. So we're really dealing with the health issues. Hopefully, eventually, this will lead to greater medical knowledge and access to medical care. But I think we're more focused right now on the cultural understanding of health and illness than we are on the science of medicine.
I have a comment and then a question. The comment is this last year I read a book entitled The Emperor of All Maladies. It's written by Siddhartha Mukherjee. It is a terrific book on the history of cancer. Going back to antiquity, looking at how cancer was treated historically, but also going through all the different ways in which contemporary societies have attempted to address the issue of cancer and deal with it, including all the wars over advertising and things like that. And it does go into quite a number of aspects of how different communities respond culturally to the problem of cancer in their midst. So it's something I would just sort of suggest would be a great read for
I'd love to read that. If you wouldn't mind, Peter, if you could just send me an email with that.
Sure.
Because I'll forget it in 2 minutes. I already got it.
I think won the Pulitzer Prize.
Yeah, one big prize. Yeah, it's Emperor of All Maladies.
Yes.
But this is really relevant as I'm going international with my HINTS research. We're trying to find out what differences there are. It'd be really neat to have that as a background.
Good, good. My question is about the kinds of theories that you're using and also the applications that you're applying to. I was kind of surprised and was curious about how the work you're doing ties to the health belief model and all the variations thereof. because it seems like there's a fairly natural tie-in there, but there must be reasons why you're either not using it because you don't think it applies, or maybe it
Well, I kind of blend that into the cultural competency model, is that the health beliefs are a lot of times based on the cultural, so it's in there, although it wasn't mean specifically. So it is part of what we're doing. One of the things we're trying to do is to move away from kind of an individual models of health to a more group-based, collective approach. A lot of health promotion, a lot of the models, persuasion models, are focused on individuals. And most of the interventions are based on individuals. We found that a lot of the successful interventions focus on the community. And so we're trying to take a broader perspective and not just look at how individuals think, but also on how cultural norms affect beliefs. And that's why I kind of rolled that into the cultural competency approach.
The health model people have done that as well. I mean, they have incorporated peer norms and other kinds of subjective aspects that are part of the community that they live in. So it looks like you're working sort of in parallel there.
Yeah, this has been kind of an approach that I've been working on for a long time. A lot of my colleagues in public health, we kind of look at community-based interventions and participative approaches. So, we're not negating the health beliefs. We realize that's critically important, but we're framing it within a cultural milieu.
You talked about finding, I guess you called it archival evidence that gave you a broader understanding.
Yes.
Could you give an example of something that surprised you?
Yes. We were very surprised in the medical records how little tobacco counseling there were for Korean Americans, because we learned it was a tremendous problem. And not only were men heavy smokers, but they were like chain smokers. They were smoking like it was like a passion, and it was and lung cancer is a huge problem. So we were very surprised that there wasn't much intervention going on, and so that's a real area. I think we have tremendous opportunities for intervention. I love that kind of data because it's not subject to a lot of the self-response problems, and it's very clean. They know exactly who's come in for counseling. The records are right there. I'll try to do that as much as I can. Yes.
Yeah. I'm really impressed by the extensive line of work that you've done for immigrants' health issues. And regarding the Korean immigrants' choice of not having health insurance and getting the medical treatments in Korea, I think among other theories and models that you used here, maybe you can think about this as a result of this rational decision making based on purely economic sense, which means that nowadays many Japanese and Europeans come to Korea to get medical treatments, and Korea provides one of the best medical services. So for Korean immigrants' perspective, it makes much more sense not to get a health insurance here, but once a year or once for every 2 years, they can go to Korea, and if they can get a medical treatment in Korea or screening in Korea, they will cover all the cost of this health insurance, and they can see their friends and family members in Korea.
And that's what we learned from a lot of the focus groups and interviews, that it was an economic issue. It was a combination of economic and trust, that a lot of the Korean Americans didn't really trust the American medical system, and they didn't like the way it worked. They felt frustrated by it, and they certainly didn't like paying for it. So we're trying to find ways of trying to get access to care that's not expensive, like maybe provide free screening through the churches, and then get it mandated by the ministers as a way of maybe helping with that. Because you're right, there's an aversion. Why would I have to pay for this when I get it for free or for very low cost? The other thing is we're trying to figure out to get people to know that they need to do this now. They can't wait a year or 2 years. It has to be on a regular basis. They need to get screening.
Maybe other things that you want to think about is that some Korean immigrants, even though they are immigrants to the United States, they might still have national health insurance in Korea.
Most of them do.
So
Yeah.
for them, they already have health insurance in Korea, so they can go back to Korea and get his medical treatments.
They do, but the problem is that they don't go very often. It's too expensive to go on a regular basis. They can only afford to go once every few years.
Yeah, it costs about $1,000 for the airplane ticket. The health insurance costs it costs a lot more than that.
Well, if we can get them group insurance, it'll be less than that. Yes?
Based on your formative research, what are some of the ways that you try to design the implementation in a more culturally relevant way, especially given like the psychological and sociological differences, and since you're looking at different pockets of Korean populations, right?
Yeah, there's a lot of things that we learned about what were the issues that were of greatest concern, what were the messages that people resonate with, and what were the examples and language choices that would be most effective. And so we're trying to use that. We also learned which communication channels were being paid attention. We found out there were a lot of local Korean magazines and newspapers and even TV shows, some of them coming from Korea, some of them produced locally that people were paying attention to that we didn't know about. And so based on that, we're targeting specific channels and we're using specific culturally appropriate messages for the interventions. And we're still coming up with that. We're going to be doing a lot of message testing before we actually go public with most of those. So we learned a lot. Yes?
Since you mentioned sustainability, what kinds of incentives are you using to keep the people engaged in this sort of multi-level complex study? And another question is, could you describe a little bit more about the participatory approaches that you're using?
Yes. I'm embarrassed to say this, but we're using almost no incentives at all.
That's great.
Because we don't have a lot of money. We've done this with some small grants. And we've also self-funded a lot of this ourselves. We're really going after the large grant now. We're looking for an R01 from the National Cancer Institute. And we're using the data that we've already collected as our pilot data. But most of this has been run on a shoestring. So we're giving almost no incentive. The primary incentive we're using is we made friends with the ministers and community leaders, and they are encouraging people. And within the Korean American community, these community leaders have tremendous authority, and people really listen to them. And so that's been we've been friendly and working with folks. And several members of our research team are parts of these communities. One of them is a member of one of the local Korean American organizations. We haven't given any incentives at all. In terms of the participation, we've connected with, and one of the in the R01 application that we're submitting now, one of our co-investigators is the president of the Korean American organization. And there'll be some funding that'll be provided directly to that organization if we get funded by NCI. And we tried to connect with a lot of people. We were working very closely with the ministers as well. And we've been trying to go to events. We've connected with people who are producing local media. So there's a very active involvement with the community. And we've been really quite welcome. At least my colleagues who are already a part of it. I really haven't done much with the Korean American community myself other than to brainstorm with my research partners. One of my primary partners, Kyung Mi-oh, is a professor in the School of Nursing, who is a first-generation Korean American herself and well-connected. And two of our doctoral students are from Korea and also well-connected to the community. And they've done most of the work with the community. Some of them are very actively involved already. So it's been relatively easy for them to make those connections.
Can I ask one last thing?
Sure.
You mentioned policy. What are some of the ideas that you have in terms of moving towards policy and getting the communities to move in that direction?
One of our community partners who has been a really big friend of ours and helped us along the way is the Fairfax County Public Health Department, which is a very big public health department. Fairfax County is a big, big county. And they have a lot of issues and concerns about the Korean American community. And so they've been working with us, and they're trying to develop new materials, new policies, new procedures. We've also been working with the Inova healthcare system, as I said, has kind of a monopoly. They have 4 or 5 big hospitals in the D.C. area, Northern Virginia. And they're very interested in working more effectively with the Korean American communities. And we've already agreed with them to provide training and support systems and materials that they can use with that community. So those are some of the policy issues.
Any other questions? Well, thank you for coming.